Hi everyone, welcome back to our multimodality imaging lecture series. It's a great pleasure to have today Piotr Slomka talking to us from Cedars-Sinai. Piotr is a Director of Innovation in Imaging at Cedars. He's a Professor of Medicine and Cardiology on the Division of Artificial Intelligence in Medicine at Cedars-Sinai. Piotr has been doing a lot of work for a long time now in artificial intelligence in cardiovascular imaging. He's in the board of directors of Journal of Nuclear Medicine, and he's very involved with the ASNC as well. So it's a great honor to have you here today. Always good to hear your lectures.
Thank you, Leandro. Thank you. It's a great honor to present here at your meeting in New York. And actually, we've met with Leandro 2 weeks ago in Central Park, and I forgot to take a picture because I was there visiting my daughter, who is in a university there at Art Institute. I hope to visit in person sometime and see your place, but this time we'll just do over Zoom. So I will be talking about clinical applications of artificial intelligence in cardiovascular imaging. These are my disclosures. And these are my collaborators. I wanted to start with this because all this work is really possible because of all these people. This refined spec registry we'll be talking about is a database which serves as a baseline sort of database for various AI approaches we test in nuclear cardiology. There's 14 sites. Those are the leaders from the sites who are working with us, contributing data. And we also work with the team in Edinburgh and of course with our team at Cedars. And here's our research team. And of course, everything now is on Zoom. We're waiting for this to change, but we're doing a lot of stuff like this every week. And this is the picture from before the Zoom times. So I will talk today about a few applications of artificial intelligence in cardiology, but especially when we're talking with cardiology and imaging, and mostly it will be about the nuclear imaging, myocardial perfusion imaging, SPECT and PET, but I will spend maybe half of the time on the CT also. At the end, I'll show you something very special we do here with coronary PET CT, which is a multimodality technique. So if we start from nuclear cardiology, and I know this is a sort of established technique, but because it's an established technique, it makes it easy to develop and test various artificial intelligence methods. So we do about 7 million scans per year in the United States, 15-20 million worldwide. Maybe 10% of this is PET, and we want to also expand it into PET. PET is now growing. We can do perfusion, we can do flow, function, and then we also have stress variables, we have clinical variables. And at the end, the clinician is presented with the tasks to diagnose the patient, to estimate risk, and provide the treatment recommendation, and sort of juggling all these different variables and findings. And perhaps we were focusing on trying to see if AI can help with this. So I will be talking a lot about this today. Our database, refined spec database, is right now we have 14 sites. I think we will have one more site, so we're close to like 14, 15 sites. To date, we collected 44,000 cases, 6,000 cases are ongoing. We want to close it at about 50,000 cases of SPECT images, clinical data, and a lot of those cases have SPECT CT. Some of them have also the new emerging SPECT flow data. So this is the kind of background of what is needed for AI, I think, to really have something versatile which will work in every place in the world. So you have here, we have outcomes, we have clinical data and images, as you see. So that refined spec registry forms like a basis for our research work in this, and we publish papers recently since 2019 from this registry. And as you can see, the AI yellow, highlighted in yellow, those are the AI papers. I will talk about those and also about some other CT papers, but we'll focus about this work which emanates from this registry. So first work is this is Julian Betancourt, who was with us. Now he's in France in aerospace industry, but we're working here on. It was the first site actually from Oregon where we said, can we actually predict Mace more accurately for when we have imaging and clinical data from spec, after spec scan, and we want to see how well we can predict Mace from this data. So this was just a one side, it was a bit first side in refined spec. And as you can see, if you look at just as a medical diagnosis, it's sort of not performing very well, sort of the normal diagnosis of the spec scan. Quantitative, because it's continuous, is a little better, but if we actually combine these quantitative features with AI, we get much higher AUC. And when you actually combine this imaging features plus clinical features, you can further enhance and refine your risk prediction for Mace. This is a 3-year Mace risk prediction in 2,600 people. As you see here on this graph, we can plot. This is a common plot in the AI world, where we plot the feature importance, which features are mostly driving this prediction. This is on a group basis. Just remember, this is for the whole population. And here we see that mostly is imaging features, stress and rest ejection fraction, stress and rest, stress TPD, and diastolic volume. So those are imaging features. There's some clinical features in green, and also stress features like the stress heart rate and why the scan was, why this was terminated and so forth. So as you see, different features will have different sort of feed importance in this kind of prediction, and all of those features are complementary and additive. We also shown in a different application. Now this is now using 9 centers from refined spec. We wanted to see if we can predict accurately who will undergo revascularization after spec scan, and this is of course to some extent sort of predicted from the spec scan, but it's still it's a pretty hard endpoint, because you really want to know if these people actually ended up with real revascularization. And you see here that, with this kind of AI techniques, we used XGBoost for this. You see that the AUC is much higher, as you see here. Clinically, if you operate at certain thresholds, you see these purple points. Those will be the physician operating at normal or probably abnormal or abnormal. And you can see that you can operate at these points, but it will not be as accurate in prediction who will undergo revasc as compared to AI. And here on the right, you see the same feature importance graph, where you see the blue imaging features are driving this prediction. Those are the most important features. But this graph, I just wanted to explain to you, is very important graph in machine learning, in AI. And this is the calibration. If we are giving a score to a patient, not particularly, we're not giving a specific just yes or no decision, the patient will undergo revascularization, but we're giving probability. We want that probability to actually reflect real probability. And here on this graph, you see the blue bars are showing you the observed, the actual ML score. So this will be the values, and the score will be 0.8. And the red curve will show you the observed revascularization rate. So you see 80% was observed in this bin, and actually that was predicted by AI. So the probability you get from AI will match the actual occurrence, or the frequency of this occurrence in real life. This is called calibration graph. It's very important in AI. This was by Lin-Chin Hu, who was in our lab here. Now, a lot of the things, this was a standard machine learning sort of classical techniques, but then everyone is now interested in deep learning, and we'll talk a lot about deep learning now, what we do with this. And of course, everyone is familiar with this seminal papers they applied deep learning to classical images to detect features in images or detect objects. This is used now everywhere in Facebook, in your phone, and so forth. We use this GPU cards here. You see this kind of a GPU farm when you have 15 or so of these cards on one or kind of a rack. But we typically have like 2 or 3 in one computer. We have also AWS server, Amazon Web Service server for that. And not getting into technical details because it's a clinical meeting, one thing to remember is that we use so-called convolutional neural networks typically in this deep learning. What this means, these networks are designed for images. So fully connected network, you may hear this, is connecting every node to every node. It's a lot of weights. But in image-based network, we typically just connect sort of neighborhoods here. And because of that, we can put a lot of layers. It's very efficient, and it sort of can understand images better. So we applied this kind of technique to deep learning, but we said we will use polar maps because polar maps are very well established sort of image coming from nuclear cardiology. It can represent motion, perfusion, everything. So we designed a network like this where there's 3 convolutional layers, and we have then some fully connected layers to further, elaborate on the final score. And in this particular applications, there was the first paper by Julian Betancourt in JACC imaging. We were giving the probability of the obstructive stenosis, and we would give it separately for LAD, LCX, and RCA, and then maximum would give you a patient score. So with this kind of approach, this was the first approach where we were putting also raw maps, also quantitative maps. Then we also had another paper on this where we showed that we can put different views. So some of these new cameras now have upright and supine views, for example, and physicians have to juggle in their heads how to, which view is more important. We were fitting both of those, and we showed that if you combine the views, it actually helps, and deep learning can be used to combine it. And then you could get that map with probabilities here. So importantly, when we did this work, and any artificial intelligence work, it's important to show that you separate training from testing. And you can go to the extreme to separate it to actually, and that's now recommended, to externally validate your model. So for example, if we develop a model in our refined spec from 3 centers, we would test it in a separate center. And we could repeat that process. So we could build these 4 models, and this way we could test it across the 4 different centers, but each time it's a different model, but it gives you an idea how this whole technique can apply, how generalizable this technique is. So this is sort of something which we always want to look in AI research, like, does it work outside of your hospital? Does it work outside of your data pool? Is it valid? So putting all this together, we've published recently by Yuka Otaki and Anya Singh in JACC imaging, sort of improved version of this. This is just came out recently, where we feed the perfusion, motion, and thickening polar maps into this neural, sort of improved neural network. We also feed the volumes, cardiac volumes, age, and gender, and we provide the probability. But importantly here, we also provide the explanation for the physician which part of the polar map is responsible for this finding. And we use this technique from computer science called GradCam technique, which is sort of developed for general imaging applications by Selvarahu. You see that they have the technique of sort of backpropagate through the network to find which parts of the network are responsible for triggering the final diagnosis. And in this case, they find a dog or a cat, and we're finding the probability of LAD, LCX, or RCA disease. We can put it in the 17 segments, assign the probability. So this will be some, the kind of system which the physician could be using clinically for helping detect coronary disease. As you see here, this is Yuka Otaki and Anya Singh. Here you see that when you have this new system, we look at the AUC of this of the performance, and you see we can beat by 5% actual clinical visual scores. Now, that may not sound like much, but the visual clinical scores are using every possible thing, including clinical information. And this is by experts in the field, and this is across many sites. Also, when you look at the sensitivity, specificity, because AUC is a global measure, we also are more significantly high. We can have the higher sensitivity at the same specificity. So we can detect 3-4% patients more accurately. And some people say, well, that's not a big number, but if you can think of about 7 million people being done in the United States every year, and if you can have 4% higher accuracy, that's a lot of people. If you compute, if a lot of people, you can in hundreds of thousands, you can detect more disease and then guide treatment better. So even though this statistically small number maybe, but it is highly significant, and I think clinically also significant. This is what such system would look like. You see here, it's a clinical prototype where the attention map will show you a defect and will show you the particular segments highlighted. The global CAD would come out as for the patient risk for having the obstructive disease 88%, in LAD 86%, and lower in other territories. This patient had 85% stenosis in the proximal left anterior descending artery. The deep learning system takes some time to train, but when it runs, it only takes about 5 seconds for this kind of result to come in interactively for the physician. So we believe this would be one way to, for the physician to learn this. Here we have a new study. This was actually presented at ASNIC. We just had finished ASNIC 2 weeks ago, a nuclear cardiology meeting, where Rob Miller was showing that does that actually help the clinician? Because before you saw it in a standalone mode, but here the physician actually is reading this, and the physician is actually can use it. And we've shown similarly that kind of setup. I think this will be the clinical setup. We have similar gain in performance. So another application, because diagnosis is one thing, it's sort of maybe a high target to use the AI for diagnosis, but important. But in SPECT, we have that scenario where we do stress and rest imaging, but a lot of the SPECT scans are actually normal. And in that situation, if you do stress first, you don't have to do the rest imaging. However, it's very difficult to decide right away on the spot when you start this imaging, if you can actually cancel the rest image. So there were papers by Dr. Mahmarian here published that, you can do this if there's certain clinical criteria and there's certain, imaging criteria, you can cancel rest scan, and you could cancel up to 60% of scans. But currently in US, we cancel only 3% of the scans. You can imagine the savings in radiation and everything if we could actually efficiently do that. So we propose to use AI for this. And in this case, you see that this is Lin Xin Hu, another paper from our lab, where we show that kind of AI prediction, like that XGBoost AI prediction could actually stratify Mace risk very high. And that's what it was used in this stress-only papers. And we can see that, that if you do it by clinical criteria, you really cannot predict Mace that well. So, and we want to have the patients who we cancel risk, and we want the patient with have event-free, like sort of low risk. And here we can see that we can have different thresholds for AI. Each of those thresholds would be superior to what can be achieved by this interactive clinical sort of decisions. And this kind of system could be automatically triaging this scans and saying, okay, well, that patient doesn't need the rest scan. When we compare and we say, if we actually set a threshold to cancel 60% of the scans, we set certain probability threshold for Mace. With that kind of threshold, and this is sort of the 60% would be normal scans. So this is like a normal clinically. So if you look at the normal diagnosis, this is the separation of the Kaplan-Meier curve, normal diagnosis, abnormal. You see there is a big separation, but if you use this another 60% of patients by separated by the AI score, you see the separation is much better. So you have this higher risk in this group and a lower risk in this group. And you can see here that actual annual Mace rate in this patients would be canceled is 2.1% if you were canceling by visual, and 1.4% if you were to cancel by this AI system, and you still be able to cancel 60%. So this is something we think this could be a very good clinical application for AI system to use it sort of on a daily basis. Of course, doctors could review the rest scan the next day, and patient could come back for rest scan if needed. But on the first go, the triaging could be performed like that. And not only this, we could also explain to the physician individually. So before I was showing you these graphs, the group graphs, where we see this on a group basis. But here we can actually show for a given patient the risks, what is driving the risk score. So there are techniques like that in AI where you can see for the particular case. And in this case, you see that that was an abnormal diagnosis. There's some abnormality, and those are the clinical features here. SSS was 4. However, if you look at this, what AI was doing, it would say, okay, well, the age is low and the body mass index was high. That could be an artifact because of that. And this reasoning here and you have various different features here. Of course, the quantitative will bring it up, the red, and everything else brings it down. This is called waterfall graph. And at the end, you see when you add all these features, your final risk score is very low. So that patient could have had breast scan canceled. And importantly, when we do this, we want to know how many variables we actually need, like how many imaging variables are actually needed. And this is Richard Rios from our lab. He published this paper recently to show that actually we don't need many of these clinical features to have this very accurate risk prediction. If we take the images, like the MPI images here, we have a baseline risk prediction of 0.75. And then if you add just about 10 different clinical features, we're just improving our AUC here. So stress peak heart rate, previous PCI, indication for test, resting heart rate, pharmacological stress, yes or no, BMI, diabetes, and so forth. And at some point, this is it. If you add more clinical features, you can't really get any better prediction. And so this kind of this tells us that this can be implemented clinically pretty easily, because we can handle this kind of small number of variables for a patient pretty quickly from either EMR or enter somehow during the scan. We actually implemented the prototype here. You see here on the scan that we can actually show this, and you can run the case, and then you can see the annualized MACE risk for that particular case, because all that information is already given from the images, and additional clinical information here like heart rate can also be obtained, or age. Diastolic pressure can be obtained from DICOM or added to the image. So now what about PET? So in PET, we actually have this great characteristic, which is flow. And this is a paper by Dr. Murthy in 2011, Venk Murthy, and it was nicely shown that perfusion and flow are additive, that it can be done. But it was showing these tertiles to show that different tertiles will add the risk. And can we do it better with AI? So this is an example of the perfusion defect and flow. And with flow, we have the curves and dynamic studies. And we have shown, this has now been shown in ASNIC, this is sort of work in progress, that if you actually combine the perfusion and flow data, and we train it, and then we test it this is data from Cedars-Sinai, we test it prospectively in new data from Cedars-Sinai. So this was trained on the old data. Now, chronologically, we tested on new data. We can detect annualized mortality risk very accurately, much better than, for example, ischemia. Ischemia, everyone talks now about 10% ischemia being sort of like a criteria for revasc. But you see, if you use, for example, deep learning score like that, how much better it can separate all-cause mortality. So on this curve, we see the dotted curves. They separate, of course, the normal, abnormal, ischemia less and more than 10%. But if you use sort of match deep learning score, you see how much better you can separate who actually is at a very high risk of mortality. So this is the kind of work we're doing right now. We could also predict, there was another abstract at ASNIC from Konrad Pieszko from our group. We can actually not only predict the risk, but we could actually show the individualized Kaplan-Meier curves with this. So you could tell the patient, for example, they had sort of similar perfusion defect, but when you add this other risk factors, you can show the individual trajectory for each patient, what kind of is predicted risk. And you can also separate the risk for different kinds of events. So you can add all these events for MACE, or you can say, well, this patient has the highest risk is for revasc. This patient, that kind of patient will undergo revasc, but the death risk is not that high. That gives you sort of like a maybe better idea how this could be done. Those are kind of new techniques in AI where you use time to event together with the AI system. So now you don't get the actual risk, which will be just like a horizontal blue line here, but you kind of see the risk over time. Importantly, we have not done that yet, but I think what's really important is to predict who will benefit from treatment. And I think I've shown you the preliminary data here that with AI systems, we can actually direct people for different treatments. It requires a little more data, maybe, how we do this, but we show that right now we use ischemic TPD 10%. And I know, ischemia trials show differently in randomized controlled trial. There's a lot of controversies about this. But in a quantitative multi-center analysis of contemporary data, we showed recently that, and there's many other studies like that, show that actually there is some benefit. But imagine if we could use all these variables, as I shown you, in AI, and we could perhaps separate these patients who actually will benefit from revascularization. So now I'd like to move on to CT here a little bit and show you the things we're doing in CT area. So non-contrast CT is the sort of like a basis, and it comes very often with PET CT and can be done standalone. And one of the things is calcium scan, which we are so familiar with, that this is a very simple technique. It's not yet universally covered in US for coronary calcium, but potentially can be a screening test. But also we do a lot of lung cancer CT scans, we do CT attenuation scans, and there's a lot of information here on the CT scan, non-contrast scan. So we'll talk about what can be done here. And this is published by a different group, by Zalesnik et al. In Nature Communication. They've shown that actually we're using deep learning techniques, which we were talking about. You can segment calcium very accurately. And they've shown in different trials here, they took data from different trials, the PROMISE trial, ROMICAT trial, NLST is the lung screening trial in smokers, and these are non-gated, those are ungated scans, and they show that this can actually fully automatically find calcium then, and this can then you can stratify the risk in this cohort. So that is so this is an application where you segment the images using deep learning, and you then use the actual calcium score, not directly predicting risk, but giving the calcium score and show on the image where the calcium score is. Where it's coming from, and this could be very importantly, can be used for risk prediction from data which perhaps was not used before. We actually work on the same thing now. We're trying to use some techniques from video imaging, some new techniques, convolutional long short-term memory networks, where we can sort of remember the slices from before and after. And using this, this is work in progress, so can't show you too much, but just a little idea that those kind of techniques are evolving, and you can segment this kind of sometimes very poor quality images. You can segment them accurately. And here's an example. We actually used it in PET CT attenuation correction map. And you can segment this, compared to expert annotation. This is a deep learning annotation. And you can see that it is not fooled by the pacemaker wires. It's also, it sort of avoids most of the stent. And it also avoids mitral calcification. So you can teach the system what is a coronary calcium and label it, even if it's a very poor quality image, in a fully automatic way. This takes only seconds to process. It's sort of like free data, which is in the hospital there. And Dami Day at our group is working with epicardial adipose tissue, also from non-contrast scans. So that can be quantified here also from this is in this case is a gated non-contrast scans, and you can quantify very accurately the volume of the epicardial fat tissue. So this is a tissue which is sort of here inside inside the pericardial sac. So this is done using the deep learning methods. So this is the methods by Frederick Commandor, published in Radiology AI 2019. And you see here that it's separate steps, a little bit like the user would try to do, where you find the limits of the heart, you then segment the thorax, and then you segment the intra and extra pericardial differentiation. You separate this. And this is done by this sort of convolutional neural networks. And then at the end, you have this map of where it thinks this, this epicardial fat is located in. Each pixel is then given a probability. This is implemented sort of in a prototype here, and you see that the user will be given, this will be automatically found, this volume will be fine, and you see there's very little difference if the expert does it versus deep learning. Expert takes about maybe 10 to 30 minutes to do it accurately, because you really have to meticulously check this border is very thin, and you have to see if there's there's an errors, and having that information coming automatically from every calcium scan, every non-contrast scan could be beneficial. And so this was validated, this is Frederick Commandor, this was validated in multi-center trials in data from 4 sites. You see there are different sites showing in different colors, and as you see, all of the sites agree on the correlation is very good between the expert annotation and the automated annotation. And this was sort of similar to what the 2 different experts would perform at that kind of level, because when you have 2 different experts, there's still variability, and deep learning system will be like another expert annotating these images. So how can that be used clinically? So for example, here, you see this is a paper by Evan Ainsberg and Priscilla McElhinney from our lab, from Dr. Day lab, actually. We work together here on this, and you see here that you have if you combine it with calcium, so you have a coronary calcium score and a low epicardial adipose tissue volume versus high epicardial fat volume, and you see here that already the risk is stratified, and the same is true for high calcium score. Even in the presence of the high calcium scores, you will have a big separation between this, if you consider this high or low epicardial adipose tissue. So this will aid very much, like this kind of fully automated information will aid very much in what you can get from just a plain calcium score in terms of risk stratification. So more of this was performed here to kind of evaluate, how different, things like the epicardial fat and calcium score can add together. And in prediction in MI and cardiac death, in this case, this is by Frederick Commodore, Cardiovascular Research. And you see when you add the different features, the clinical features and imaging features, and the calcium scores, the number of coronary lesions, and then you also add this, epicardial fat volume, you can achieve very high prediction for cardiac death and MI. And you see here that like calcium score itself is similar to ASCVD, but adding this all together, you can achieve a much better prediction, and sort of like you can look at this point on the AUC curve that you will be, significantly higher for the same specificity. You can outperform the calcium score by almost 10% and by almost over 15% ASCVD. So even though the AUC curves there's small difference you can see, but for a particular operating point, it may make a big difference. Another study here where we show this kind of idea of this personalized explanation, just like I showed you for the stress-only scan. This is BK Tamara Pu from our group, who is now in Indiana, published in Atherosclerosis. You can see that the AI scores can be sort of combined here. So we're combining this deep learning EAT volume, we're combining with calcium scores and the clinical features and also biomarkers. And you can see for individual patient, we can show, okay, well, that's a high risk patient. Some features, that's going to be low risk patient here at the end. You have the waterfall graph. The features are sort of contributing to lowering the risk in this case, with like a low calcium score and no epicardial fat. But here, you'll have another case which will be high risk, age and other factors here will add to the high risk, and the imaging features will not reduce that risk in this patient. So those are the kind of graphs you could present individually per patient, and if a clinician is given average, like sort of risk, like their average risk for events, that could be very helpful in guiding therapies and so forth. So what about contrast CT angiography? So we've actually worked quite a bit on this in a study with Confirm Registry, where we shown, this is Manish Motwani, you can see him on actually on Twitter, Doc Tiger, very prolific Twitter user, and very interesting thing sometimes. And here it was a great paper we've worked together on, where we shown that, and this was done with a contrast CT angiography, where we did not use the sort of quantitative features yet, but was a visual features derived from CT angiography. We then combined this with clinical features, and we found that for all-cause mortality 5-year prediction in this 10-fold cross-validation, we separate the training from testing using these 10 different folds. We find that that kind of AI approach would significantly outperform the Framingham risk score, the segmental stenosis score from CT, or segmental involvement score, or Duke index. So combining this kind of data in this integrative fashion, it really helps you to provide accurate risk stratification also for CTA. This was in 10,000 patients from Confirm. However, you can. This was done in the data which was visually assessed from CTA. So there was the visual assessment was entered into the AI system. However, here you see that you can quantify data. This is work of Dr. Day from Cedars. You can quantify plaques accurately, and you can quantify the non-calcified plaque and calcified plaque. And you see there's a lot of different quantitative plaque parameters which can be obtained for each vessel and for each lesion. And so can we somehow use this information in the AI system for risk prediction? So first of all, if you see this quantitative plaque, this is a paper by Michelle Williams and from Edinburgh, and from Dr. Newby and lab, and Dr. Day lab also here. You see that quantitatively, we can predict that low attenuation plaque, it really is a very powerful risk prediction factor, which outperforms other factors like stenosis, calcium, and total plaque burden. This was derived quantitatively from CTA. And patients with this low attenuation plaque are 5 times more likely to have subsequent myocardial infarction. So one of the things we're trying to do now is, because still that kind of techniques take a little time to quantitatively assess, to fully automatically derive this from the CTA. So here you have an example of one work. A lot of this is going on right now, but here's an example where we find accurately the stenosis from CTA, fully automatically segmenting, just like we segment the calcium scans. We segment here the coronary scans. And you can see the deep learning, versus expert reader. There's a very little difference here, and you can see here on these different cuts. So this was tested in 716 segments in this 10-fold repeated holdout. So there is always training and testing is separated. So if you can derive these parameters accurately like that, you can then integrate them further in this quantitative AI prediction. So here we see that the fractional flow reserve is something which is used in the cath lab for treatment recommendation. And can we predict, for example, taking all this quantitative features, can we predict low flow fractional flow reserve? And in this case here, in the study by Dr. Day in European Radiology, you see that when you add this different plaque features, the light blue, and the clinical features, you can very accurately predict the low FFR, and this has been then validated externally. Also, that you can predict as compared to stenosis or just pretest likelihood. So you can actually use this as a kind of a guideline to what kind of invasive FFR will tell you, and that will give you potentially those kind of systems could give you a very good integrative information about the potential risk or potential treatment recommendation. Here's an example of application of this score to predict revascularization from CTI. This is published by Alan Kwan from our lab here in European Radiology. And you can see that when you use this score for what's the probability of low FFR here in LAD. For example, here that patient has a high probability of low FFR in LAD. And this patient has very low probability. even though there's a significant plaque here, but taking all these features together, somehow it will give you this probability, and then you can see that kind of approach, when you just use stenosis alone versus clinical information, if you combine this, you have that AI score for predicting low FFR, it can predict who will undergo revascularization pretty accurately. So at the end, I like to show you something very different. And that's something we work with a group in Edinburgh, where we also try to apply AI, but this is a pretty sort of non-standard technique, but I think this will be potentially future technique in high-risk patients in hybrid multimodality imaging. So you probably have heard of this, that we can use PET imaging for sodium fluoride, with sodium fluoride, and that is used typically for bone cancer. So you'll see these lesions, and this is a tracer which accumulates in bones. However, the group in Edinburgh, in this landmark paper from Lancet, they have shown that actually this sodium fluoride, which is sort of something which you find in your toothpaste, but this is a radioactive version of it, that it actually accumulates in plaques. And it accumulates in plaques. This is a multimodality image here, which was shown on BBC, and sort of Mark Dweck here shown on BBC, that heart attack risk is identified by new scan. Now they jumped the gun a little bit here in 2013, because at that point they were showing that it was associated with MI, not really predicting risk. However, we work with the group with this group for a long time. Now we've developed new techniques for quantitation of this. So as you see here, you have this is Jacek Kwieciński working on this with us, finding how you best quantify this tracer uptake, in like to sort of quantify the total burden of this uptake in the vessels, rather than using the standard total like a target to background ratio, which was used before. And then we also do special motion correction techniques and so forth. And once this kind of techniques are applied, this actually was shown, this for the first time only 7 years later, it was shown that this actually predict risk of myocardial infarction. And actually what's significant here is this is in patients who are very high risk. So these patients have stents, a lot of calcium, and they already have previous MIs, and the sodium uptake is very highly predictive of the subsequent heart attacks in these people. This is work by Jacek Kwieciński and Vangelos Solos, got a Parmley Prize. We're very proud of this just in last year. So this kind of techniques, this is at this point, this is not AI technique. This is a improved quantitation technique, and then but you see there's a lot of CT information here and PET. Is it possible to put it together? So actually, in this manuscript now published by Jacek Kwieciński in JNM 2021, we've shown that yes, the sodium fluoride is really very, very powerful predictor in these patients. The clinical parameters, nothing clinical really works. This is even like taking all the clinical scores, every possible information about these patients, and using AI techniques to try and predict the outcome of subsequent MI. And here you see that the sodium is performing the quantitative plaque analysis. Each of these parameters was not that predictive, but putting it together, it gives you the AUC of 0.72. But if you actually now combine the sodium fluoride and quantitative CTA, so those are the different features in this feature importance graph which go into this prediction, and you see that importantly here, the contrast density difference on CTA in these patients, the sort of the contrast before and after the lesion is very important. The sodium fluoride parameters are coming up here in blue. There's the low attenuation plaque, which you've seen in that paper by Michel, is coming up here. And then there's a lot of the sodium fluoride parameters. Some clinical parameters are, but not very important, as you see. And the overall risk prediction is significantly improved. So those kind of, I think this AI techniques will be very useful where you have this diverse multimodality scores and you try to sort of put it together in some ways that you try to come up with some overall risk score. This is, as I said, this is a very not yet commonly used technique. This is now used only in clinical trials, but we can show what the power of this, the application of this in potentially in the future. So in summary, I would like to say this AI, that we could, we can use AI to quantitatively diagnose and predict outcomes in cardiovascular imaging. And we can enhance the quantitative patient-specific risk and improve diagnosis by AI. And the AI techniques will assist in mental integration of multiple parameters. I showed you many examples how these multiple parameters can be integrated and giving you like a global score. The clinical application is stress-only imaging, diagnosis, risk assessment, potentially treatment benefit. And artificial intelligence can also automate image segmentation, because there's a lot of mundane operator-dependent tasks. This can be done by the users, but takes a lot of time. But physicians will always be a supervisor of artificial intelligence, will be able to enhance precision and will be given explanation, and they can focus on the patient. So this is how we see this field developing. Thank you very much.
Thank you so much, Piotr. That was amazing. And as Mark knows, we're so busy here that we're waiting for AI to come help us. So we're not scared. But that was great. So Mark will join us for the Q&A. I will start with one question. So I really like that paper that you guys published on the use of CCTA in very high calcium in the JCCT recently. Do you think that AI could help establish before you inject the contrast if based on a calcium score you will provide a diagnostic CCTA or not?
So yeah, I think certainly we can try everything, and certainly I think that it's it's even possible that people work on this. There are papers already to show that you can generate contrast image from non-contrast image with AI techniques. So I will have to see how accurate this will be. But I'm sure there's a lot of information in the non-contrast image which we are not yet fully and unraveling from that scan. I believe it that given the right outcomes and giving the right training and data, we could show that there is more in the scans which we could learn from. So we'll have to see. I think contrast CTA is a great technique, but we see how much it adds. Yeah.
Thank you.
I have a question. There's big concerns about costs of things. And I was looking at some of the graphs of the artificial intelligence, and one struck me that a lot of things added a little thing, including the imaging, but once age came, it really increased it. And I would argue, well, age costs nothing. And if I just had age, gender, body habitus, diabetes, then maybe in terms of cost, the nuclear thing wouldn't add much. Cynics may say that. So how do you address that?
Yeah, it's a very good question. Thank you, Mark. So yeah, I also always think about this because I'm also try to be practical, and some people like work in AI and say, what about age? And I say, well, we didn't use age. I mean, what do you mean? Like you have it for free. So I agree. And like there, if you look at the literature, there's a lot of papers about age, and it has extremely high. If you take like all hospital data, if you go to Cedars and take like a whole data set, age will be very predictive of mortality, of course. And I always wonder about it. And my colleague from ECHO was showing me some papers. It's like so predictive, like AUC 0.8 for age. And I said, why do we even do PET at all? Like, so it got me thinking about this. And we checked age prediction in like our groups, like what I showed you, PET. It's not very high. It's like 0.6. It's low. And why is that? It's because these people are very similar age. Like people who come like for PET are older, and there is some variation. And then we talk about like a 1-year mortality, for example, prediction. Age doesn't play a big role. But if you take a population from like in the hospital from a newborn to 100-year-olds, yeah, then it's going to be more predictive. So you have to always look at the data. The AUC is not everything, but it does add. But for example, in the PET studies I showed you, this is something we're working a lot now. It doesn't seem age adds a lot, maybe 1%. It adds to your overall prediction. For like say 1-year mortality. If you have flow, that is like a very dramatic, definite number which trumps age and everything. So in that sense, I think we will have to learn how to maybe derive like a biological age from the scans, or like kind of because there are, of course, like the life tables from Social Security. You can look how much risk increases with age, and you can somehow normalize this and get, some kind of value saying, okay, maybe this patient is 5 times at higher risk at that exact age. So I think for what we do, age is important, but it's incremental.
Well, so that might mean for different ages, you might want to have different curves. Like if you're taking a group of 50-year-old people, it would work one way with the artificial intelligence. You take a bunch of 80-year-old people, it'll look differently. So these may need to be done differently for different groups. Maybe also for different ethnic groups would have things.
Yeah, exactly. Yeah.
Someone from Bangladesh, I just thought we have a lot of those patients, and they all have coronary disease. So
yeah, and that is exactly right. But this is why AI technique, that's why we believe in this idea here with AI, because like this is exactly what cardiology tries to do. For example, they try to say, well, for men and women, it's a bit different, and we'll do different graphs. And then, but men and women with diabetes, and then men and women with different age, and you just start dividing into the small subgroups, and you get like 20 patients maybe in a particular group. But AI is actually allows you to put it all together, and then, as I showed you, this individuals, like, so then like actually you can derive the individual care for a patient with, for that age is actually different care, for that age is different care. So I think the way to do it is like put it all together, because it's like one model, but it then is driven by these different factors, and then you explain these factors for that particular patient. So I think that would be the approach for this. Yeah.
That's great. Thank you. We have a first question from Toshiki Kuno, one of our fellows. He asks, any thoughts of using XGBoost versus neural network? Also, how many important features to use for the final model in general?
Yeah, very, very good question. So we work with both. Our experience, it may vary for different things. Our experience is that XGBoost is a really high performing system, and there is a whole books on XGBoost. So it's not like people take XGBoost and just run it. There's all kinds of ways, you know how you use it, how you hyper tune the parameters. I think it actually, there is this Kaggle competitions. This is the system which is used mostly, which is winning all the AI competitions. So we think for kind of classical machine learning, where you don't deal with images, which you just deal with the numbers and like spreadsheets and large number of numbers, for us at least, this is the technique of choice right now. There's other techniques, there's many one, but they kind of like XGBoost kind of encompasses a lot of this. And we find that performance-wise is consistently across different data sets, we get a better performance. And that, you compare to logistic regression, even, or many other techniques. How many parameters you need is a very good question. And we've shown, for example, that in that XGBoost application published by Richard Rios, that as you just increase the number of parameters, you just end up maybe with 10 parameters, and it's as good as having 100. So some people believe in a huge number of parameters. Like I've seen people, you can train it on 20,000 parameters, like you have genomic sequence or something. But I think it just ends up overfitted. You end up fitting some very, very kind of fine models, and you just take it to another site, it like all falls apart. So this kind of more parsimonious models, I still believe in this, even though like AI likes to take many variables. I think small number is good. But of course it depends on the application.
That's very good. I think it's something that will be very interesting at some point is also to be able to predict the value of revascularization, right? We see so many patients that keep getting revascularized without risk factor control, with high blood pressure or very high LDL.
Yeah, exactly. So I think this is exactly like the kind of the holy grail of cardiology. If we can actually efficiently predict for this patient, yeah, you should do revasc. And it's not just because the perfusion is low or some CT value it's because of the whole phenotype of that patient, that patient is actually, and I think a good clinician is actually doing that in their heads anyway already, right? Like this is what's going on. It's not as simple as just sending someone for revasc if they have TPD of greater than 10%, or I think it's a complex process, and we have to learn about this. And AI is just a tool for us to kind of unravel this and kind of and show this in a kind of more quantitative way.
That was great. Very, very interesting topic. Thank you very much, Dr. Travin, for joining us. And, hopefully we get with all this extra added value that the insurance companies don't keep asking for plain ECG, and they see the value in all this and start investing.
Yeah, because we definitely see, we see the value, we see the imaging adds a lot. And, as I said, 3-4% may not sound like a lot, but it's a lot of patients being diagnosed correctly or stratified correctly. On a global scale, it will make a big difference.
Great. Well, thank you very much, and we hope to see you in New York City soon.
Yeah, I'll be coming here
Come to the Bronx.
Yeah.
Bring Dr. Berman and Damini too.
Yeah, thank you. Yeah. Okay. Thank you for inviting me, and see you soon.
See you soon.
All right, thank you.
Bye, Mark.
Bye.